Okay, we're now live. Hello, everybody. It's April 10th, not April 15th. It's not tax day. Hope everybody's doing well in this world of lots of redos, and I will not discuss tariffs. I do remember tariffs when I was in elementary school, I guess, when we first learned about history and tariffs and things like that, but haven't heard about that in a very long time. Anyway, I chose a title this week on AIs, and one of the things I just wanted to make the point, and we won't have a very long talk today, but the fact that there are a million articles every week on AI, which I do see, and I read a lot of them, and it's always the challenges of AI. We're looking at early detection of pancreatic cancer. I think we have some really good data. We're doing this final testing on looking at small tumors. We think that probably having the high 90 detection rate for under 2 centimeters. Radiologists are 70%. So every day there's new things. There was an article in the New England Journal about a drug discovery where somebody had put all their symptoms in a physician and went through all the world's literature. And for years ago, someone suggested this therapy. Therapy was done, the patient was cured, otherwise the patient was terminal. And that's not like one of those People magazine stories that are very nice, but that's reality. There's an article this week published the other day in Annals of Internal Medicine, comparison of initial AI and final physician recommendations in AI-assisted virtual urgent care visits. So what they did is they wanted to compare AI recommendations with the final recommendations of physicians who had access to the AI recommendations and may or may not have viewed them. So what they were trying to do was see, when you looked at physician visits, they looked at 461 visits, and they looked at the AI recommendations and how the patient should be managed for a range of symptoms. And then they looked at the clinician's recommendations, and then they compared them and made some changes. So here's what happened. Initial AI and physician recommendations were concordant in 56% of the visits. So AI and the physician said the same thing. All recommendations were more frequently rated as optimal compared with treating physician decisions. Now, what's interesting is the AI recommendations were felt to be superior to the clinicians. Quality scores were equal in 67%, better for AI in 21%, and physicians better in 11%. What does that mean? When AI and physician recommendations differed, and about 2/3 of the time they were the same, AI recommendations were more often rated better quality. Findings suggest that AI performed better in identifying critical red flags and supporting guidelines adherent to care, whereas physicians were better at adapting recommendations to changing information during consultations. Obviously, AI can only make decisions based on the information. If you would have added new information during the visit or later on, physicians would have an advantage there. The paper concludes AI may have a role in assisting physician decision-making in urgent care situations. I thought that's very important because we're saying, we're not trying to say AI versus physician, you only get one. We're trying to say for the future, for the near-term future, you're going to have a physician like you've always had, but they're going to be supported by AI. If you look at this data, what it's saying is the AI will make very good recommendations. 2/3 of the time, it'll be what the physician thinks. That may make him or her feel more comfortable in their decision process because they have some agreement. But in 1/3 of cases, they'll differ. And in 2/3 of the cases where they differ, the computer is the one that's correct. So now, if we put the clinician and the AI report together, and the clinician uses AI in arriving at the final conclusion, the patient will be the beneficiary of this because you're going to get the best comments and the best management. And this is in a real world setting. This is not theoretical. And most of the names on the article were physicians. So a really, really multi-center. It was done by Cedars-Sinai and several other institutions and several researchers. So it's definitely worthwhile taking a look at this. This is in the Annals of Internal Medicine, this just literally about 3 days ago. So that part's really, really good, and I think that's a very exciting and interesting way to go, and that's where things are going. In radiology, we're seeing a lot of stuff on breast, which we have been seeing on. It's been clear that AI for screening is probably as good or better than physicians. There was an article published in Radiology this month that shows AI is more accurate in determining who needs to get a follow-up study and who doesn't. And AI with the radiologist does better than the radiologist alone. So again, just to enforce, what we're seeing is AI is making a difference. It can make a difference by itself. So in places without physicians, that may be very important. But in places like most of our practices where there are physicians, though they're very busy and overworked and all the usual adjectives, AI will help them make better decisions so the outcome for our patients is better. So read those articles, look at that space, look at CTisus. I put the articles up every month, about 100 plus articles that are published on AI that I think are valuable. And with that, I hope everybody has a great day. And those of you who are celebrating Passover, Passover starts on Saturday night, the first Seder. I wish everybody a happy Passover. And those of you who are not celebrating Passover, I wish you a happy weekend. And hope all is well. And with that, be good, everybody.